Medical Center. I'm currently serving as the resident advisor for WCVIS Chicago and previously was acting as the education chair. And so today I wanted to kind of reach into the third installment of our IR Playbook series, which is chapters 10 and 11, covering acute and chronic lower extremity DVTs as well as PE. So it's always important, before we start studying any topic that we really understand why is it important. And so kind of four big reasons why DVTs and PEs are super important, especially with IR, is the incidence of DVTs and PEs. So with DVTs, it approaches around 117 over 100,000 person years, which realistically, what does that mean? For every 100,000 people observed in a given year, 117 new cases of DVT arise. Incidence also increases with age. Those that are 85 years old see a 10 times greater incidence of DVTs. It's also really important to recognize that there's an underdiagnosis problem that occurs with DVTs and PEs. Surprisingly, many thrombotic events or instances are actually clinically silent and therefore underdiagnosed, and incidence is actually much higher than what is reported. Because of this, there's also severe problems with underrecognition and misdiagnosis, and autopsy studies have shown that a third of fatal PEs in the hospital and ICU setting were underdiagnosed prior to death. Some of the long-term consequences also make this really important. Patients with index thrombus have a 10 to 30% probability of death in the first month, particularly from PE, and recurrence reaches about 30% at 10-year mark. And then 17% of men and 40% of women experience chronic venous disease. One of the biggest manifestations that we'll talk about is post-thrombotic syndrome, which occurs in about 50% of patients following an initial DVT episode. And then finally, it's the medical costs. VTE, which includes both DVT and PE, carries a significant economic burden and quality of life impacts for patient, for providers, for everyone involved. Advanced chronic venous disease can cause leg ulcers, for example, which results in direct medical costs of around $10 billion worldwide and over 2 million lost workdays in the US. Post-thrombotic syndrome itself can cost about $7,000 a year in care per patient. So really jumping first into the pathophysiology of DVTs. The way we'll kind of take this is the pathophysiology, then we'll go through diagnosis and management, and then finally the interventional stuff, which is the fun stuff, but it's foundational to understand this first. So when it comes to pathophysiology, acute DVTs really consist of an inner platelet-rich thrombus surrounded by an outer RBC-dense fibrin network. And some animal models have demonstrated that venous thrombi are heavily fibrin mediated, which, if you'll remember, is related to secondary hemostasis, whereas arterial thrombi are platelet mediated, mainly with primary hemostasis. So, some of the conditions that predispose someone to VTE, it's really surrounding Virchow's triad, which I'm sure, as we've all learned in med school, consists of endothelial damage, stasis, as well as hypercoagulability. So the main risk factors for VTE are going to be trauma, which is all three components of Virchow's, surgery, again, all three components of Virchow's, malignancy, which it's well known that generally cancer creates a hypercoagulable state, prolonged immobility, which is again mostly stasis, congestive heart failure, stasis and endothelial damage, obesity, increased age, pregnancy, which is a normal state of hypercoagulability, as well as genetics, things like factor V Leiden, prothrombin gene, as well as protein C and S deficiency. An interesting fact with regards to these risk factors is that about 50% of DVT associated with surgery actually begins intraoperatively. And so when you're talking about DVTs, you have to really get down to the classification. Is it a proximal versus a distal? Is it a provoked versus unprovoked? There's a lot of different parts here. So when we're talking about proximal versus distal, proximal occurs at or cranial to the popliteal deep veins, while distally occurs caudal to those veins. Proximal has a high risk of dislodgement and PE and requires anticoagulation or, in certain select patient groups, IVC filters, whereas isolated distal DVTs can be managed with 2 weeks of serial imaging, and then you escalate care if thrombus propagates to the popliteal. And then iliofemoral DVT, which is classified here as a proximal, carries an even higher risk of PTS, post-thrombotic syndrome, as well as recurrent DVTs. And now when you're thinking about provoked versus unprovoked DVT, it connects to those conditions and risk factors that we talked about just a second ago. So provoked DVTs arise from a known event that served as the risk factor, whether that was trauma, surgery, immobility, whereas the unprovoked DVT refers to those without such an associated event. What's really important for the clinician is identifying the inciting factor because that has implications for your anticoagulation choice. If you're having a provoked DVT, for example, a patient came in just after having orthopedic surgery, you might want to do anticoagulation for 3 to 6 months. Versus someone who's unprovoked, you don't know what that identifying risk factor is. You're going to lean towards lifelong just because we don't know what's causing that. Subsequent VT events also requires indefinite lifelong anticoagulation. So when it comes to the pathophysiology of chronic venous disease, abbreviated here as CVD, you really want to think about venous reflux and obstruction, with both play the major roles in the development of CVD. Combined, this ultimately results in venous hypertension and stasis that is exacerbated in a gravity-dependent position. For example, if someone's standing up, the gravity-dependent position is within their lower extremities. So those two components, reflux and obstruction, let's talk about that a little bit more. When it comes to venous reflux, the main things that cause that are valve incompetence, inflammation, as well as reduced pump function in your calf muscle, which is important for sending blood back up to the heart. However, in patients who have venous reflux, this results in venous pooling. And then when you have a thrombotic outflow obstruction, having that DVT causes altered hemodynamics in the veins, vessel damage, as well as decreased perfusion, which also leads to venous pooling. So when you're talking about chronic venous disease, it's actually a range and a spectrum of sequelae that occurs after that initial DVT. And it's most commonly and notably characterized by PTS, post-thrombotic syndrome. And so post-thrombotic syndrome can range from anything from mild leg swelling all the way to unrelenting leg pain, edema that's refractory to compression, or ulceration. Some of the risk factors for developing PTS include iliofemoral or iliocaval venous occlusion, which by our definition earlier is a proximal DVT, if you've had pre-existing CVD, obesity, or increased age. So kind of looking at some of the images here, at the bottom left, we have on the left side there, a DSA demonstrating a post-thrombotic occlusion of the left iliac vein with a scarred lumen. And then on the right side, you can see some of the sequelae, the clinical symptoms that occur when you have this post-thrombotic syndrome. This could look like ulceration or a couple of dermatologic conditions, whether that's lipodermatosclerosis, dermatitis, or phlebolymphedema. And so looking to the right side of the slide here, we have some more topics talked about with regards to compression syndromes. So there is also non-thrombotic CVD, which occurs when there is venous compression secondary to other anatomical structures, whether that's arteries or bones. The most common non-thrombotic iliac vein lesion is actually known as May-Thurner syndrome, which is a big PIM question that you'll get asked on your IR rotations. And it occurs when the right iliac artery compresses the left iliac vein against an adjacent bony surface. That could be, for example, a vertebra, or in certain anatomical structures, it could be the hip bones or some of the lower extremities. This results in intimal hyperplasia, scarring, flow stasis, as well as increased risk for DVT. Now, the important thing to realize here is that iliac vein compression can actually be asymptomatic in around 40 to 50% of patients and can never result in clinical symptoms until suddenly a patient pops up. So it's really important to be aware of these non-thrombotic CVDs because that can also cause problems for your patient in the future. And then I also wanted to include an image right here in the top right of a digital subtraction angiography as well as IVUS, which demonstrates the compression of the iliac vein. And so in this left side image here, you can see the arrows pointing towards this area of compression right here, where there's like a little spur in the vessel. And then the IVUS here in the middle demonstrates a compressed vessel versus on the right side here, it's an open, normal, healthy vessel. So you can see quite the difference here, where there's a clear outline in the normal, healthy vessel. And then here it's completely occluded. And so when it comes to diagnosing and really figuring out what to do with acute DVT, you really want to see patients who are experiencing acute DVT, what are they going to present as? It's going to be your pain, redness, warmth, edema, and it's all going to be unilateral and localized to the affected extremity. Distal pulses will often be normal because, again, this is venous, not arterial. And some really important PIM questions here for physical exam. Holman sign is when a patient has calf pain with dorsiflexion of the foot. Meyer's sign is where compression of the calf muscle results in pain. And these are all indicative of DVT. But of course, you need much more than just your physical exam. So one of the most common initial diagnostic tests for DVT is the duplex ultrasound. And so findings that you want to look out for a positive exam includes vessel non-compressibility, which if you'll remember, a normal healthy vein should compress. But in this case, because there's a clot there, it's kind of impeding that compressibility. That's why you will have vessel non-compressibility. And then for two, you will have the absence of a Doppler signal. Three is absence of respiratory augmentation. Blood vessels will often exhibit some kind of phasic activity and movement with respiration, but there will be absence of that in a DVT. And then sometimes you might also see hypoechoic or hyperechoic intraluminal material. So that's kind of demonstrated here in this image where you're really talking about the compressibility. And so on the right side here, we have a vein that's completely compressed. It looks pretty flat. Whereas on the left side here, there's an artery and vein paired up. However, the vein does not compress when the sonographer is trying to push the ultrasound machine down. And then some other imaging that we want to talk about is adjuncts, such as CT or MRI. These can be particularly useful for assessing the deep pelvic and abdominal venous structures, especially when it comes to CT venography. That can inform any sort of compressive anatomy like the May-Thurner syndrome that we were just talking about. However, when you're considering the adjuncts versus duplex ultrasound, it's important to note that sensitivity and specificity for a duplex is around 94% plus. And then when it comes to treatment goals, so what is the whole purpose of treating acute DVT? It's really to mitigate the risk of PE, as well as decreasing the post-thrombotic syndrome sequelae. So an important trial that's fairly recent is the ATTRACT trial, and it demonstrated the VIL-ALTA score can predict those who would benefit from intervention for DVTs. And then that image there just shows what is included in the VIL-ALTA score, as well as the parameters for interpretation. And so now let's talk first about conventional therapy, which is going to be our anticoagulation. So it's really the cornerstone of all non-interventional therapy, and selection depends on your bleeding risk, comorbidities, preferences, as well as convenience of your anticoagulation um, modalities. Generally, DOACs, your direct oral anticoagulants, such as apixaban and dabigatran, are preferred over your vitamin K antagonists like warfarin. On the other hand, vitamin K antagonists like warfarin are preferred over low molecular weight heparin, such as enoxaparin. And so treatment time is generally going to be 3 to 6 months, but it's altered based on your DVT characteristics. And it's also important to note that in cancer patients, low molecular weight heparin is actually preferred as first line instead of a DOAC. And then when it comes to your proximal DVTs, they're associated with a higher incidence and severity of post-thrombotic syndrome despite optimal medical therapy. It's important to note that of patients treated with anticoagulation alone, 40% off eventually develop venous claudication. So it's really, when you think about this, the proximal DVT patients will benefit from frontline endovascular therapy to reduce that thrombus burden ahead of time. And so when it comes to chronic venous disease, the benefits of anticoagulation are actually less clear. Low molecular weight heparin, when it's used, is often favored post-intervention because in addition to anticoagulation properties, it also has anti-inflammatory properties, which is part of that pathophysiology, right, of chronic venous disease. When it comes to compression stockings, which is a popular treatment that we hear about, there's actually controversy surrounding it. Some of the older randomized control trials using compression stockings have demonstrated some clinical benefit, while newer, larger RCTs have shown no difference in the risk of developing post-thrombotic syndrome long term. However, compression stockings are still a useful hands-on thing that patients can have and can benefit their own quality of life, so it should be still considered. And so now to the fun part, we have the interventional therapy. So we're going to be talking about thrombolysis as well as thrombectomy. So when it comes to acute DVTs, the treatment paradigm is once again mitigate PE and reduce the incidence and severity of post-thrombotic syndrome. So because of this, the mainstay of interventional therapy is going to be called thromboreduction, right? Reducing that clot burden, and that can be done via catheter-directed therapy. Now, CDT itself can come in multiple flavors. You can have catheter-directed thrombolysis. You can have pharmacomechanical CDT, also abbreviated as PCDT, or you can have mechanical-only CDT. So just walking through some of these options here, let's first talk about the CD thrombolysis on the left side. And so what this is that you're having a targeted direct infusion of fibrinolytics, such as TPA, into the thrombosed segment via an infusion catheter. Often these will have multiple side holes, and it's kind of directed right into the clot to infuse this thrombolytic there. And even though this is a strong therapy, it is associated with significant bleeding risks, and it does require ICU admission after the intervention is completed. When it comes to some studies and data about this, the CAVINT trial demonstrated a 14% decrease in post-thrombotic syndrome risk in an interventional group where you're using this catheter-directed thrombolysis plus standard of care versus if you're just using standard of care alone, which consisted of compression stockings and anticoagulation. And so now when it comes to the mechanical only catheter-directed therapy, what this is it physically captures thrombus without the use of any lytic. So some of the mechanisms that we can think about are aspirating the clot, literally vacuum it, meaning you're kind of using a interventional tool to break up the clot itself. Rotational force, which uses high spinning objects to essentially break up the clot again, as well as high pressure saline jets, which is also known as rheolytic therapy. And so what was interesting here is that the rheolytic therapy actually creates a vacuum that pulls the clot out while the high jets actually break up the clot. And so when it comes to some data here, CLOUT is an ongoing single arm registry that uses the Inari clot retriever. And some of the outcomes that have come out from this mechanical only CDT is that 85% of patients have had complete clot removal, which was defined as greater than 75% of clot removed. And 90% of patients were free from post-thrombotic syndrome at a 6-month follow-up period. However, it's important to know that the clot registry, it's not randomized control and it's still ongoing. So we're still waiting on data for that. When it comes to PCDT, or otherwise the pharmacomechanical CDT, you're simultaneously or sequentially infusing lytics with mechanical therapy, which technically should decrease recannulization time. So kind of going back to that more recent ATTRACT trial, it assessed intervention, which was using PCDT plus anticoagulation versus anticoagulation alone in a multi-center RCT. All in all, to say that it's a very good trial. And so some of the outcomes from that is that moderate to severe post-thrombotic syndrome was less incident and less severe in an intervention group over 24 months compared to the anticoagulation alone group. And so now when you're going to how to do all this, what the steps are is you essentially want to first select your access site. Oftentimes this will be the femoral vein, the popliteal vein, or the posterior tibial vein. Then you're going to start performing a venogram to characterize what this thrombus is like. And then you're going to maneuver your catheter to the thrombus segment, determine what type of CDT you want to use. Again, it's either mechanical, thrombolytic, or combined pharmacomechanical. And then you're going to perform whatever that type is. Finally, you would repeat your venogram and consider doing balloon angioplasty or stenting after the fact. And so going on to some of the interventional therapies when it comes to chronic venous disease, we have to talk about venoplasty as well as stenting. So when it comes to venoplasty and stenting, these are both options for CVD. Many acute iliofemoral DVT cases have a chronic iliac vein component that requires venoplasty as well as stent placement. So since the 1980s, it's actually been a long-term treatment. Venous stent placement has been shown to be safe and effective at improving symptoms. So going through some of the trials here, the C-TRACK trial has shown that it's an ongoing trial, but it's evaluating stent placement in ilioobstructive PTS. When it comes to the vernacular study, it found that there was primary patency rates of the stents of 84% for iliofemoral disease at 3 years using Venovo. And then for the Abre study, which was using the Abre stents, its primary patency rates of 88% for iliofemoral obstruction at 12-month marks. Even though it seems very simple and pre-procedural planning is very critical for conducting venoplasty as well as stenting in your CVD patients. Some of the things you want to consider are patient positioning, the extent of iliofemoral disease, play a role in whether your stent will hold and be patent long term. When it comes to traversing really long segment occlusions, especially some of the iliofemoral or iliocaval ones, it's often difficult and requires a lot of support catheters, wires, and adjunctive crossing methods like sharp recanalization. And then if multiple stents are deployed, stents must overlap to avoid gaps in your disease coverage. And then when it comes to deploying your stents, you often have to post-dilate them in order to ensure complete expansion across the affected segments. So kind of looking here at the bottom left, the left side image is a left iliac venography that demonstrates a post-thrombotic occlusion of the left common femoral vein as well as the left iliac vein. And then the right side here is what the patency looked like after recannulization and stent placement. So there's clearly a great restoration of patency that occurs with this venoplasty as well as stent placement. And so briefly talking about the utility of IVUS, it's a really cool and upcoming thing that's being used even more and more in the interventional suite, as well as other interventional fields. But IVUS is an intraprocedural tool that's often used in venoplasty as well as stenting. In this context, it's really used to determine the proximal and distal landing zones, sizing the vessel, characterizing the degree and location of obstruction, as well as differentiating between acute and chronic clot depending on echogenicity of that clot. The video study suggested that IVUS has increased sensitivity in distinguishing iliofemoral vein stenosis compared to more traditional conventional venography, such as axial. And it supported interventional planning by visualizing lesions that were not previously identified. So it's really great at helping IRs as well as other interventionalists adapt during the procedure and form new interventions based on this, what they otherwise wouldn't have gotten through conventional venography. And so, kind of just looking at the top picture here, the IVUS is quite literally a catheter with an ultrasound attached at the end that emits a beam. And it's going to produce these circular concentric images that show the vessel lumen. It will show you any sort of thrombus that's in there, as well as any other findings that you might need to see. And so now kind of going on to PE here, we have to talk about the pathophysiology of PE. And so PE is a result of one of those DVTs, a venous thrombus, traveling from some sort of peripheral source to the pulmonary arteries. And once it gets there, it lodges and can initiate the coagulation cascade. But there's two different outcomes that can occur when this coagulation cascade is initiated. Either you can have clot dissolution, which is also called endogenous thrombolysis, or clot aggregation, which then results in the clinical symptoms and presentation of PE. So it's important to see that the lung actually routinely filters small clots, which are known as subclinical PEs, and it's incidentally found in about 2% of all CTs, which this helps prevent thrombi from entering the left heart circulation. The problem is when these thrombi lodge and do not get cleared by the lungs. And so a lot of those same conditions that predispose a patient to DVT also predispose a patient to PE. I won't go through all of them, but some of the additions that we want to talk about is that autoimmunity also creates a state of hypercoagulability. When it comes to prolonged immobility, it's actually considered a weaker risk factor for PE, but still a risk factor nonetheless. And then OCPs as well can create a normal state of hypercoagulability. And so when it comes to the pathophysiology of PE, once an embolus is large enough, it's going to increase your pulmonary vascular resistance, which leads to a whole series of events. So kind of running through this a little bit here. Having a PE, it's going to result in increased pulmonary artery pressure. Eventually, this will lead to increased right heart strain, which is characterized by decreased contractility, decreased output, ischemia, increased O2 demand, and so on. Eventually, this right heart strain, it cannot be overcome. And so it's going to lead to decreased right ventricular output, decreased LV preload, and then eventually you're going to get decreased cardiac output, which, as you'll remember, cardiac output is defined as heart rate times stroke volume, and it's the stroke volume is composed of your preload, afterload, and contractility. So all in all, this will eventually cause obstructive shock and death. So what is the goal of treatment here for PE? It's to diagnose and treat the PE before this process reaches the final stages, which is your LV dysfunction and reduced cardiac output. The challenge with this is determining who should we treat, when should we treat them, and how to treat these PE patients. And so below is just another diagram that kind of goes through the circle all the way from increased RV afterload to death and really kind of breaks down the pathophysiology of PE. And so kind of going through the diagnosis of PE here, once again, we want to diagnose and treat PE before it reaches those final stages. So how do we determine who to treat, when to treat, and how to treat them? So the most straightforward answer is going to imaging, which is going to be your CT angiography. It's proven to be more reliable than VQ scans, as well as less invasive than catheter angiography, which was the gold standard previously. Additionally, it has the added benefit of visualizing the pulmonary arteries directly, and it allows us to evaluate the right ventricle. Now, it's common to learn in med school that chest x-ray is useful for PE because you get Fleschner's sign and Hampton's hump and all these things. However, it's not sensitive or specific for PE. And actually, most PEs appear as normal chest x-rays. So it's not really that clinically useful to get a chest x-ray beforehand. Some people will also often use EKGs to see evidence of right heart strain, whatever it might be. But it's important to note that most PE patients will just show up with sinus tachycardia. So it's a pretty unremarkable EKG otherwise. And so when it comes to classifications of PE, I'm sure we've all heard about terms like massive PE, submassive PE. It's kind of hard of how do we determine what's massive, what's not. And so one of the common mistakes that I was making when I was an early student here was that this image here shows a saddle embolus, which looks really scary. It's a thrombus that's kind of straddling the pulmonary artery and reaching into both of the left and right main pulmonary arteries. And so how do you determine what's a massive, what's a submassive? This looks pretty bad. And so, according to the 2011 AHA guidelines, a massive PE is a clinical diagnosis. It has to have systemic hemodynamic instability, whether that is a person is in shock, they're having pressor requirements, whatever it might be. But a submassive PE has no signs of systemic hypotension. So, what's the difference then between a submassive and a low risk PE? There has to be evidence of right ventricular strain. All of these are once again clinical diagnosis. It cannot be made based on presentation or imaging alone. And so now you've kind of understood the differences between massive, submassive, low risk. What are some of the imaging we do? How do we know who are we going to treat, right, based off of these characteristics? So you have a couple of different risk stratification and score systems, but some of the most common and up-to-date ones are the PESI as well as the SPESI, which is the SPESI just as a simplified version of it. But both of them are single prognostic scoring systems that predict 30-day acute PE mortality. Some of the key parameters of this is having an age greater than 80, having any sort of history of cancer, history of chronic cardiopulmonary disease, a heart rate greater than 110 beats per minute, a systolic blood pressure of less than 100, and having an arterial SpO2 on room air of less than 90. So all of these are signs, if you can kind of connect it back, of having this massive PE, right? Lots of hemodynamic instability. So what's really notable here between the PESI and the SPESI is that for the PESI, there's quite a bit of risk stratification between what's high, what's low mortality risk. The SPESI, you only need 1 point to be high risk. So kind of use your clinical judgment. Some providers will have different preferences when it comes to which scoring system to use. And so kind of going on to our conventional therapy, once again, we're talking about our anticoagulation. So it is still the cornerstone of your non-interventional therapy. And similar to DVT, your selection really depends on your bleeding risk and comorbidities. But kind of different from DVT here, your initial acute treatment depends on what classification your patient is. So if you have a low risk PE, you can actually treat that without any hospital admission with a DOAC. Whereas intermediate and high risk patients, they should be admitted to the hospital and treated parenterally, preferably with a low molecular weight heparin over unfractionated heparin. The reason why is because unfractionated heparin only achieves therapeutic targets in a third of patients at 48 hours. And so when it comes to your acute PE, patients should all receive a minimum of 3 months of anticoagulation, preferably once again with a DOAC. If patients have some sort of reversible risk factor, for example, they have a provoked DVT from recent surgery, they may be able to stop therapy at that 3 month mark. However, all other patients should continue full AC to 6 months, and then you can reconsider at that time. When it comes to high risk acute PEs, you also want to consider these patients are hemodynamically unstable. So, how can we support them? Whether that's with IV pressors, oxygenation therapy, any sort of other respiratory support. What other thing you want to think about is if there's hemodynamic instability that's refractory to these measures, patients can also be started on ECMO. They can be given systemic reperfusion with thrombolytics, or they can have surgical embolectomy. But you have to be really careful with using systemic thrombolytics, particularly if a patient has a contraindication. And so some of these absolute contraindications for having systemic thrombolytics includes any sort of active bleeding, if the patient has had a cerebrovascular accident within the last 6 months, if they have a history of hemorrhagic stroke, if they have an intracranial neoplasm, or if they've had major head or any sort of trauma within 3 weeks. And so going on to some of the more fun things here, we're going to talk about the interventional therapies for PE, which is really comprised of thrombectomy. So what are the endovascular therapies? It can really be divided into two major categories, which is going to consist of aspiration thrombectomy as well as catheter-directed thrombolysis. Currently, the only indication for endovascular therapy in PE is being high risk or having that massive PE. But it's unclear if any intermediate risk patients benefit from intervention versus using just anticoagulation alone. Regardless, any form of intervention should be accompanied by that full dose therapeutic anticoagulation. So, kind of going through some of the different methods here for thrombectomy, you have first off aspiration. So, a lot of modern aspiration systems use around a 12 to 24 French catheter to rapidly remove clot and restore flow. And what this ultimately does is it allows for improvements in your RV/LV strain, tachycardia, as well as improved pulmonary artery pressure. Aspiration, however, can lead to excessive phlebotomy, injury to the right heart, as well as the pulmonary arteries. And because you're using such a large catheter to pull out this clot, you can have severe access site complications. And then when you want to talk about other catheter-directed therapies, you have ultrasound-assisted thrombolysis, which, similar to your conventional, right? It uses multi-side hole catheters that are placed into the pulmonary arteries and infuses lytic agents using ultrasonic energy. So theoretically, what this does is that it expedites the thrombolytic process by cavitating and broadly distributing the lytic agent into the clot. It's important to know, however, that this requires infusion of NS for cooling the system. And so when it comes to your conventional catheter-directed therapy, it's kind of what we talked about before, using the same multi-side hole catheters, small size or expandable, and it's infusing lytic agents into the pulmonary artery without that ultrasonic energy. Regardless of modality, there's still controversy with regards to what dose of lytic agents should use, how long should therapy be, and what are the endpoints to determine that therapy. Is it the time that we spend doing the thrombectomy? Is it the dose that we give the patient of lytic therapy? Or is it clinical outcomes like evidence of reduced RV strain or reduced pulmonary artery pressure? It's still kind of unclear what those endpoints are and what should be agreed upon as acceptable for therapy endpoints. And then when it comes to long-term outcomes here, some of the major outcomes of acute PE are going to include complete recovery, post-PE syndrome, your chronic thromboembolic disease, otherwise known as CTED, as well as chronic thromboembolic pulmonary hypertension, or CTEPH. Now, CTEPH occurs in about 3 to 4% of patients following their first PE, and it's often going to manifest as exercise limitations. And what this is ultimately caused by is this chronic pulmonary artery hypertension. And so that's why these patients eventually develop exercise limitations and can even go on to develop right-sided heart failure. And so these are my references. It was a pretty brief and broad overview of DVTs and PEs, but hopefully this kind of prepares you guys for some of your IR rotations as well as any sort of clinical experiences you guys have in the future. And just want to thank the WCVIS Chicago team for allowing this project to come to life in another Playbook series. And so here are some of the QR codes as well to connect with us, whether that's the membership form and the group me. And if you're interested at all in signing up for the IR Playbook series, there's a QR code as well where students can do some of these lectures. But at this time, I'm happy to answer any sort of questions that anybody has on the presentation. And thank you guys.
Thank you, Zach. That was awesome, per usual. I guess I can get us started with questions. You briefly talked about IVIS, and I've been hearing about IVIS all the time recently. Have you seen it used before in cases, and then in what cases have you seen it used in? You're muted right now, Zach.
Sorry about that. Yeah, it's used in a ton of different cases. I mean, like we mentioned, especially in your venous and vascular cases, just because it's quite literally a direct imaging modality that's live in your cases, right? When you're using IVIS, for example, when you deploy a stent or you do an angioplasty, how can you be sure that a lot of that thrombus is pushed up against the wall or that patency is there, right? You wouldn't necessarily want to. Fluoro is kind of unreliable for that, right? But if you use an IVIS, you're actually going directly into the system and seeing where that clot is. And so I'll try and go back to that slide here where it was, but if you can actually see directly right here. And so it'll show you, right? This is the inside of the vessel. And so you can imagine here that if you had some thrombus remaining, let's say after you did an angioplasty or a stenting, then you'd want to go back in and kind of redo that area, right, with another balloon angioplasty or extending your stent. If you didn't have IVUS, then you wouldn't really know that there's an existing thrombus there, and therefore your intervention would stop there. So the beauty of IVUS is not that it's not just that it's a new imaging modality that you could use in procedures. It's really that it changes your interventional planning live in the case. And you don't have to go back and do repeats. The patient doesn't have to get another needle stick, right? It's mainly used in a lot of these vascular applications, but I have seen it used before in some of your GI interventions, whether that's like tips or biliary stuff, because that also kind of shows you the patency of whatever duct tube that you're in at that point.
I have another question, if nobody has one. So you were talking about PE treatment modalities. I know you've been in a few PE cases yourself. I'm wondering how the department determines what therapy they choose to use. So there's obviously been a lot of trials that have been coming out recently. So like you've Storm PE, Hypetho. I'm wondering like how a department chooses like mechanical thrombectomy over CDT.
Yeah, for sure. So a lot of departments, it really depends on what's available at your site and how big of a site you are. Because as with many things in medicine, it really depends on your business partnerships too. So a lot of sites that are larger, for example, in Chicago, that might be like Rush or Northwestern, where they have a ton more connections, they have an investment from an educational standpoint to participate in these trials. They're going to be using a lot more of the newer modalities. For example, mechanical thrombectomy is actually much more of a newer therapy than infusing lytic agents. And so they might be participating in some of the newer trials with, for example, Inari with the Clout study, right? Whereas these smaller centers that might be in a community-based setting or a rural setting, they may only have your lytic agents available. So that's kind of the main distinguisher of where an institution might choose one over the other. It also really depends on updated clinical data, right? A lot of stuff in medicine kind of goes back and forth between, oh, lytic therapy is better versus mechanical thrombectomy versus a combination. And so it's really what is the up-to-date data showing us? And so that's kind of the short and sweet answer for that.
Sweet. Thank you.
Any other questions at all? If not, just want to say thank you guys for coming once again, and I hope you guys were able to learn and take away some things from these lectures. If you wanted to ever go back to some of these slides or some of the lecture talk, we will be posting this as well on our YouTube account, and then I'll also be able to share the slides with the groups as well. So I'll hand it off to Nick now. If you guys have any further questions, you can always reach out to me, or we can message later on email or anything like that. But thank you guys.
Awesome. Thanks, Zach. I'm gonna stop the recording right now. Thank you everyone for coming. And like Zach said, this is gonna be posted on YouTube, just like all of our other Playbook series lectures.